a good one. Written by a Keller, I think. What are bowling balls used for? Bowling balls, what are they used for? If you get this, I'd be really impressed. Marbles for elephants. Yeah, I know. Think of the author, though, okay? That might have been the 5-year-old. What stays in a corner but travels around the world? What stays in a corner but travels around the world? Who said it? Stamp. Someone said it over here. A stamp. That's pretty good. Not quite as clever as the marbles, but... All right. This is where we left off. We're on the skeletal system, which is a system. We transitioned a little abruptly to this slide because the slide before was talking about, backing up one slide just to orient us. This slide was talking about the histology, and if you remember, we were kind of left off on this, as you were packing up, we were left off on the advantage of osseous tissue. So it has a structure that really drives its function, and the structure is one that is not solid bone. The structure is one that actually has open space. That open space means that you can have strength, but you can actually do this efficiently. So you have these open spaces, so the force vectors that follow mechanically in bone are created or are developed based upon the stress that you put on the bone. We'll talk a little bit more about that theme here in a moment. And then the vacant space in between is where we have this marrow tissue. And that marrow tissue has a function, and that's where we begin today. This function of bone marrow. Well, it's soft tissue. It's found between the trabeculae, and it's found in the medullary cavities. The medullary cavities of the long bones. And mostly or predominantly in children is where you see a lot of the medullary space occupied by bone marrow. We have red bone marrow as a classification, and then we're going to look at yellow bone marrow next. But red bone marrow is considered our physiologically active bone marrow. It's called hematopoietic tissue. There's a fancy word that you can use. Hematopoietic tissue. That's a word that actually means it forms blood cells. It creates new blood cells, like red blood cells as well as white blood cells. So the red blood cells, the white blood cells, as well as platelets, all come from hematopoietic red bone marrow. We have a distribution that's a little different in children versus adult. In children, like I mentioned just a minute ago, all the medullary space that you can possibly have is packed full of this hematopoietic tissue. Why would that make sense? I'll ask the question earlier than I typically do. Why would that make sense? Challenges? Yeah. So children need likely more frequently red blood cells and white blood cells. The white blood cells are to fight off infections or challenges to the immune system like a cold or a virus. And the red blood cells are to carry oxygen. Well, children who are growing and in a growth spurt, by the time you reach your age, your growth plates are probably closely or are already closed. So you're not going to grow dramatically. You might increase in size or in girth. Your bones might get wider or stronger. You might become more muscular or more developed. But height-wise, you're not going to make, say, 25 to 30% more tissue in your body. Okay? Your heart's not going to typically grow another 25%. Your lungs are fully developed. Unless you grow in height, that's where the lungs actually grow, is in height. So by the time your growth plates close, you don't really have this dramatic turnover of tissue. And so you only need it for maintenance. And so the maintenance that we need means that our bone marrow that's hematopoietically active starts to shrink. In children, all the medullary space of the long bones is packed full of bone marrow, hematopoietic red bone marrow. In adults, we find it in the pectoral and the pelvic girdles. So the pectoral girdle is in the shoulder complex, and the pelvic girdle is in the waist, okay, or the two os coxa as you put them together. We find it in marrow in the skull in adults, and on the very proximal ends of the humerus and the femur. So the larger bones of the arm and the leg. So it's not that it goes away completely, it just shrinks in its overall distribution. Now yellow bone marrow, in contrast, this is mostly made up of fat cells or adipocytes. It's what replaces the red bone marrow. So in a lot of our medullary cavities and our long bones, where we had red bone marrow, we have what we call yellow bone marrow. It can convert back to being hematopoietic if it's needed. So if there's an emergency like a chronic disease or illness, you may convert back that yellow marrow into red marrow so that you can use it again. But as we get older in our geriatric years, so above 60, 65 years of age, it starts to become more gelatinous in type, and it loses its ability to be reversible. Interestingly enough, and then I'll take your question in the back, this gelatinous bone marrow, so it goes red to yellow to gelatinous. The gelatinous bone marrow has been identified to be present in a couple of clinical subsets of patients. Patients who have HIV or AIDS, they have an early onset of gelatinous bone marrow. In patients that are wrestling with chronic anorexia, and in patients that have aggressive cancers with malignancies. So in those three subtypes, we see that our hematopoietic marrow capabilities gets compromised. Question in the back.
Just to clarify, hematopoietic and hematopoietic are interchangeable, correct?
Yes. The question was about the interchangeability between sort of two different spellings or two different pronunciations.
Is the gelatinous the marrow, right, their bones get more like as you get older, or is that just...
That's different. We're going to talk about that probably on Wednesday. Why do our bones get more brittle as we get older? Well, I want to stop for a moment and take this time to talk about this application. If you have bone marrow that's compromised from any type of disease, why is this a problem? Is essentially the question. So let's discuss that, and then I'll come find your question. Here's some answers to this question. What's the importance of the bone marrow? And sometimes the best way to look at it is if you look at an extreme, right? And that's why I'm posing an extreme example. Sometimes it's easier to see if you have a control to compare it to. So the control here is what's the extreme? Well, what happens if the bone marrow becomes compromised? What are some of our results, do we think, in this patient? Bone marrow becomes compromised. Chronic infections. Agreed? What else? Okay, so less ability maybe to exert upon exercise. Remember that little activity we did at the beginning of the semester where I had to whistle when I got on the stage? That wouldn't work so well for that patient. Lower blood counts, maybe. So like red blood cell counts would be down. We would call that what? The patient would probably present with anemia symptoms or be considered anemic, right? Which means that they would have low oxygen carrying capacity because they would have low levels of red blood cells. You with me? What else? There was another hand.
Would there be a change in bone structure due to the resulting imbalance of osteoblasts and osteoclasts?
Possibly. So the bone marrow itself, remember, is some of the precursor tissue to like the osteoblasts. So yeah, you might have a misbalance between the osteoblast, osteoclast designation, and you may see some brittleness to the bones. Okay? So that kind of answers, in some way, one of those questions of brittleness as we get older. If we have less marrow, we may see less bone regeneration capabilities. We also have a problem with calcium, which is the big one that I was going to go to, but that's actually a good point. I'd forgotten about that one. What else? There's one more. Think about the cell types that the bone marrow gives rise to that we just listed off. There's one that we're missing. We talked about white blood cells, we talked about red blood cells, and we talked about platelets. What do platelets do? Blood clotting. So you may see some clotting compromisation, right? So this patient may be somewhat compromised with respect to the ability to clot their blood. Okay. Let's talk about how the bones are made. There's two main processes, two main mechanisms that we're going to go over. These are how bones form and develop. We call this process osteogenesis or ossification. Osteogenesis meaning bone formation, ossification meaning hardening or calcification. We have two main types. We have what we call intramembranous and we have endochondral. Okay? Intermembranous and endochondral. Intermembranous actually is the process that defines how bones form in the skull. Flat bones. Endochondral is a process that describes how bones appear in most other places of the body, and it begins with a cartilaginous template. First you make cartilage in endochondral, and then you actually replace the cartilage with bone cells and you harden the template. So we're going to talk about both of these, but first up is intramembranous. So intramembranous, again, flat bones, like the best example that we like to use is the skull. The bones of the skull. Not necessarily the bones of the cranium, but the bones of the skull that make up the cranial cap. Okay? Or facial bones. Not necessarily facial bones, but cranial bones. This is at about 8 weeks of development. And these bones that form the cranial cap, or the bones of the skull or the cranium, form from mesenchymal cells. So these are mesenchymal cells that come from the middle portion of the embryonic tissue, known as the mesenchyme. You can see here a mesenchymal cell, and we delineate sort of a condensing sheet in the middle. This darker layer here are these mesenchymal cells as they're starting to stack together. They start to condense. As they condense, they actually hollow out little areas. And those little areas are where blood capillaries can begin to develop. So very early on, right from the beginning, the mesenchymal cells start to pack in, and they start hollowing out little areas where you're going to have blood vessels. And why is that important? Well, pretty soon you're going to get to a thickness of bone where diffusion characteristics are going to be limited, and so you're going to need a new vascular supply. And so you think about it ahead of time, and you create spaces for those blood vessels. Over here, step number 2. Here we deposit tissue by osteoblasts. So these mesenchymal cells start to differentiate And as they differentiate, they start laying down new cell types known as osteoblasts. Those osteoblasts can lay out matrix of bone. And you get the entrapment of older osteoblasts. Remember, last time we were together, the osteoblasts take residence and they turn into osteocytes. And some of these osteoblasts are putting out their own matrix, and they leave a space for themselves to live in, known as an osteocyte. As the osteocytes form, you get this periosteum that forms on the perimeter. And obviously on the inside is where you're going to get the endosteum. But you early on form this perimeter in close connection to where those blood vessels were strategically placed. Step number 3 down here. You continue this formation. You grow these vessels out. You enhance the architecture. And you start arranging it into this trabeculated format. The osteoblasts continue to crank out minerals, laying down the matrix. And this creates these hold spaces in the spongy bone that eventually become that marrow cavity. Step number 4, you get some additional condensing that takes place. So you pack this down a little bit. Here you're seeing the elements of diploid. So you have your spongy bone in the middle. You have your osteoblasts on the perimeter, followed by the periosteum, which you'd set up here in step number 2. And then on the bottom, like a sandwich, like we talked about, diploid, meaning two-sided, you have the same exact format on the bottom. And so now you've got your trabeculated, or your spongy bone in the middle, with compact bone sandwiching it on either side. And if you look in lab, if you were able to, if you see any broken pieces of flat bone, and you open them up in cross-section, you would see exactly that architectural format. So this develops from mesenchyme, the middle portion of the embryonic tissue, mesenchymal tissue. Now, if we continue to lay out some of these steps here, I kind of walk through the whole thing, but step number 2, which is over here, we isolate or we highlight the osteoblast activity. So I walk through the same 4 pictures, but I kind of rifled through all of this language without clicking the slide over. So let's go over to it. Osteoblasts dominate phase 2, right? Phase 1 is dominated by mesenchymal cells. If you want to have a cell type that predominates in these different phases, they'd be mesenchymal cells in phase 1, osteoblasts in phase 2. Those osteoblasts are laying and cranking out matrix, like we know, they're bone-building cells. They eventually become osteocytes and take residence. You get the initial creation or architecture of trabeculae, but it's exaggerated over in step number 3, the trabecular format. So in step number 3, you have the formation of the compact bone. You begin to compact the outside. You enhance the architectural arrangement of the blood vessels. You hollow out the bone itself, creating that spongy appearance. And then finally you're left with this diploid bone as we build bone from intramembranous ossification. Intramembranous, it means kind of like between 2 membranes. So if you look here, you're creating 2 membranes of bone on the edge, and then you have bone in between. So that's how you can remember this one, intramembranous. So if we look at the skull, the flat bones in the skull eventually fuse. When the baby is born, these flat bones are not completely fused. And you have joints in between the cranial bones. Right? Well, they're not completely fused because, why? Why do you think they're not completely fused at birth? So the baby needs to come out the vaginal canal. Okay? Childbirth can be aggressive. Okay? So you want the head to be able to flex for both baby and for mom. Okay? What else? The brain isn't finished growing. The head, the cranial cap, even the facial bones aren't quite done developing. They do sort of develop and fuse early on in pediatric ages. But instead, in the very beginning, we have these sutures. And there's a fibrous connective tissue joint between skull bones that actually creates these fontanels. These fontanels are what we call soft spots. So that's the baby's soft spot. If you've ever seen a very young newborn baby, probably in the first year of age, and if they were the type that didn't have any hair like mine, and they were pretty much bald, then when they got all wound up, screaming and crying and stuff, if you look very carefully on the surface of the head, you could actually see where the fontanels were because they would pulse. You ever seen that? You can feel them. You could feel them if you have to touch very carefully because you're feeling cerebral spinal fluid as it's pulsating. Okay? So you could, get them all irritated and then, measure their... No, I'm just kidding. If they get irritated on their own, trust me, they do that. You can just observe, and then you try to calm it down. Okay. But these fontanels that develop, they close. The frontal fontanel closes first. That's the anterior fontanel. The 18 to 24 months is when it closes. It closes last. The other ones close first. So the sphenoidal, the mastoidal, and the occipital all close within the first year of life. It's only the frontal anterior fontanel that closes later after the first year of life, 18 to 24 months. So this allows for additional growth in that year 1 and year 2 of the brain and the skull cap. So the nervous system is not fully developed when a baby is born. Now evidence of that is their vision is not ideal. If you've ever watched a newborn baby, right, trying to focus on you, there's at some point they start realizing that the world is actually not blurry, right? And they're like, right? So the nervous system continues to develop, the central nervous system and the peripheral nervous system. Evidence of that is babies don't come out walking, right? There are other mammalian species where their nervous system is more fully developed at the moment of birth. And the little infants are like whales. These whales, they're mammals, right? They start swimming right away. Okay, little calves. Horses. They can actually walk relatively soon, within the first couple of hours of being born. Okay, that's not the case for humans. So our nervous system is more intricate and complex, so it takes a little bit longer to fully develop, and that's why we need a little bit more space. Okay, flat bones. Let's move on to our second category known as endochondral ossification. What is this one? Most of the bones in the body are formed via this way. The example that we like to use for this one are long bones. Short bones grow under this method as well. But the two categories, to make it simple for next week on Monday during the exam, if we're talking about intramembranous, which we just talked about, think about flat bones of the skull. If we're talking about endochondral, think about long bones as an example. And those are two clear categories that won't confuse you. So, this one's a little different. Instead of mesenchymal cells giving rise to osteoblasts, we have mesenchyme becoming hyaline cartilage during development. This happens at week 6 of development. This is all in utero. So before it was week 8. But the mesenchymal cells, because they skip the cartilage stage, they just go straight to osteoblasts. Here, at week 6, in utero, in development, embryonically, we get these cells, these mesenchymal cells, becoming hyaline cartilage, and they lay down a hyaline cartilage template. So the limbs that are forming in the developing embryo at week 6, as early as week 6, are cartilaginous in makeup. The hyaline serves as a template and then you ossify it as you move through these sort of 6 different stages of ossification. So let's look at them one at a time. Step 1. You can see this is the early cartilage model at 6 weeks of development. And here we've got this cartilage template. We've already designated a primary ossification center where we're going to begin to hollow out the inside of the long bone. And then we've organized a periosteum, or a surrounding cover. So the trigger for the bone collar to form is the invasion by blood vessels into the perichondrium. So the perichondrium is the template surrounding the cartilage. As soon as a blood vessel, which you know cartilage doesn't usually have blood vessels, remember? As soon as a blood vessel enters, it sort of triggers it to say, okay, we're not going to be cartilage anymore. Blood vessels here. And so now it forms a periosteum, and it's going to begin the signal of hollowing out the inside. Osteoblasts in that periosteum start to differentiate. And now you have bone cells, osteoblasts, that are showing up, and you're going to start building bone right away in the periosteum. Okay? So this vascular invasion is kind of our main first step that helps to delineate, this is no longer going to be cartilage, this is going to be bone, and I'm going to put this outer shell that's a periosteum with osteoblasts so I can start building bone. And I'm going to start to hollow out the inside and give some space for this blood vessel to actually develop. So, still at step 2, these chondrocytes go through hypertrophy. They start to swell. They get bigger. That's an enlargement in size, hypertrophy. This signals a secondary signal that says, let's start to mineralize or ossify or harden the matrix that we're living in. The collar that was surrounding it, right, starts to cut off circulation to the cartilage cells. Those are chondrocytes. Those chondrocytes start to disappear. As the chondrocytes disappear, that matrix deteriorates, and that's actually what stimulates and says, okay, we're getting rid of the era of cartilage, now let's bring in the bone. That hollows out this primary marrowcyte, and as the chondrocytes, the cartilage cells, you can circle this and say cartilage cells, as they go through this programmed death known as apoptosis, this is an organized cell death, that creates the opening so that the blood vessels can actually expand. Why do we care that the blood vessels expand? Why do we care that we open up a space so the blood vessels can expand? To facilitate hardening of the bone, to allow for osteoblasts to receive nutrition so that they can actually lay down the matrix that they're supposed to. Okay? Now, if we go to step number 3, here, filling in more of the details, we get this periosteal bud. This periosteal bud forms. What does that mean? Well, you get this inside cavity that's allowing this to elongate and form this marrow space that allows for hematopoietic cells to be delivered by this vascular supply. You can't have hematopoietic cells in the marrow if you first haven't invaded it with a blood supply. So now you've got blood vessels coming in. They can deliver hematopoietic cells. Those are the precursor cells that lead to the marrow. You can also allow nerves to grow in. Nerves need oxygenation just like any other tissue. And you are facilitating the ability for osteoblasts and osteoclasts to take residence, because they're going to need a nutritional supply and a way to remove waste products for those osteoclasts. Those osteoblasts help to establish a primary ossification center. That primary ossification center is the middle diaphysis, or the shaft portion of the long bone. All the way down it. Not necessarily in the middle where the marrow is, because now that's hollowed out, but all along the edges to both epiphyseal ends, the proximal as well as the distal epiphyseal end. As these osteoblasts differentiate and form this ossification center, they deposit additional matrix over this calcified cartilage. They harden it again and again and again. And the spongy bone spreads as it ossifies. So what it does is it spreads from the middle outwards towards both epiphyseal ends. And you start to elongate the bone. All right, step number 4. This medullary cavity actually starts to form, where you're allowing these hematopoietic cells to take residence and differentiate, or that's a fancy word to say, turn into marrow, bone marrow. Osteoclasts help to continue to hollow out the inside of that marrow cavity, because osteoclasts degrade bone. And then you start to set up our secondary ossification centers, which now happen on the established epiphyseal ends. We first started down the shaft portion, now we're on the ends of the bone. And what we're going to see happen is, as we get the secondary center from the primary center, we actually have this part of cartilage that's left over. So in step 5, you actually see the development of our epiphyseal plates. Epiphyseal plates, during our younger years, as pediatric patients, before they harden and close off, are made up of cartilage. That is the relic cartilage model from when you were actually in utero. I got a little excited about that. Sorry, I pushed some of these buttons. There we are. Okay? So it's step number 5. The blood vessels invade the head portion of the bone now. And the process that happens at our second center is very similar to what happened at the primary center, with the exception that we don't hollow it out. We actually invade it with blood vessels, and we deliver more osteoblasts. We don't want necessarily a marrow cavity, because we're not going to try to elongate it any longer. We're actually trying to cap it, bookend it. And then our future growth is going to happen, we'll talk about it, from these two cartilage lines. And the bone's going to grow down in one direction and up in the other. And on this one, it's going to grow proximal in this direction and distal in that direction. Okay? And then once you reach post-puberty and you reach a point of terminal growth, then it completely hardens and calcifies, and that hyaline cartilage is no longer present, and it's completely bone. Question?
Does the cartilage also turn into your articular cartilage?
No, the cartilage, the articular cartilage is a different process altogether. Yep. The articular cartilage is completely different. Other questions?